Assalamu alaikum and a very good morning to everyone. Honorable Chairperson, Co-chairperson, distinguished teacher, my dear colleagues, beloved intern, and all respected attendees. I, Dr. Syed Rakibul Hassan, Indoor Medical Officer, Department of ICU, CBMCHB, warmly welcome you all to today's scientific seminar titled Comprehensive Approach to a Patient with Quadriplegia and Respiratory Failure requiring mechanical ventilation. This topic is an extremely important and clinically relevant issue in modern critical care medicine. We hope that through this session, we enhance our understanding, improve our clinical decision making, and ultimately ensure better patient outcomes in our ICU. Before beginning, it is my honor and privilege to request our chairperson, Professor Dr. Muhammad Aminul Islam sir, and co-chairperson, Dr. Lipon Kanti Bhowmik sir, to kindly come on the stage and take their seats. Thank you, sir. Now, I would like to request our today's speaker, Dr. Anindita Modak Shruti, Indoor Medical Officer, Department of ICU, CBMCHB, to deliver her speech regarding today's topic.
Respected director, sir, senior teachers, Assalamu alaikum. Today we are coming with a very good cases, two cases with a summary of history. Actually, these are common presentations, but modalities of treatment vary according to the presentation. So let's see now. I request Dr. Anindita Modak Shruti to present her case. Thank you.
Thank you, sir. Adab, Namaskar. A very good morning to everyone. I am Dr. Anindita Modak Shruti, working here as an Indoor Medical Officer, Department of ICU, Community-Based Medical College and Hospital. I would like to welcome you all in today's clinical seminar. Today, I will discuss the clinical approach to patients presenting with quadriplegia who progress to respiratory failure requiring mechanical ventilation. We will walk through two real case examples focusing on importance of early recognition, diagnostic highlights, management principles, and then timely respiratory support along with targeted therapy. I hope you all will come along. Thank you. Our first case, clinical overview. Our first patient is a 57 years old man with no major medical illness. He had a history of upper respiratory tract infection 10 days before clinical presentation. Thereafter, he developed rapid ascending paralysis, starting mainly in the lower limbs, that progresses to involve upper limb within 24 hours, which was very rapid. There was no bowel and bladder involvement initially. Patient presented to the emergency department with difficulty walking and standing, weakness in all four limbs, and there was paresthesia in his hands and feet. At presentation, my patient was conscious and fully oriented. His cranial nerve examinations was initially normal. There was no facial weakness and normal eye movement. Motor examination showed flaccid quadriplegia. Upper limb on MRC grading was 2 out of 5, which indicates active movement when gravity is eliminated. In the lower limb, the MRC grade was 1 out of 5, which indicates flicker or trace of contraction. His reflexes were globally absent. There was mild distal sensory impairment, numbness and tingling were present. Respiratory assessment revealed labored breathing. ABG parameter shows pH 7.3, partial pressure of carbon dioxide 48 mm of mercury, partial pressure of oxygen 79 mm of mercury, bicarbonate 24 milliequivalent per liter. This ABG parameter is consistent with respiratory acidosis with increased carbon dioxide retention. On investigation findings of this patient, CSF analysis shows elevated protein level with normal CSF cell count, that is albuminocytological dissociation. On nerve conduction study of this patient, demyelinating polyneuropathy, which is consistent with our present case, that is Guillain-Barré syndrome. MRI of the spine has ruled out any structural spinal causes. On other routine laboratory investigations, there was no significant metabolic or infectious derangement present. This figure represents sensory nerve conduction changes in my patient with Guillain-Barré syndrome. Here we usually identify prolonged distal latency, decreased nerve conduction velocity, slowed and reduced amplitude of the ray. All of these are consistent with peripheral demyelination, that is also consistent with Guillain-Barré syndrome. The patient experienced rapid decline in respiratory strength. ABG parameter shows pH 7, which is acidic, partial pressure of carbon dioxide 94 mm of mercury, partial pressure of oxygen 76 mm of mercury, bicarbonate 41 milliequivalent per liter. The ABG parameter deteriorated significantly with severe acidosis and carbon dioxide retention, which is a hallmark of type 2 respiratory failure. My patient was electively intubated due to progressive type 2 respiratory failure. He was kept on mechanical ventilation for 7 days. The mode was selected SIMV, that stands for Synchronized Intermittent Mandatory Ventilation. There was a preset of mandatory breaths synchronized with patient's own efforts, allowing the patient to breathe in between the mandatory breaths. When the patient was hemodynamically stable, we have monitored the patient for other autonomic instability, such as arrhythmia and BP fluctuation in the further days. We have also taken other supportive measures during his whole ICU stay. Deep vein thrombosis prophylaxis was taken by low molecular weight heparin infusion and compression stockings. Chest ulcer prophylaxis was given. Patient was given on chest physiotherapy and suction on regular basis. After achieving all winning criteria, the patient was successfully extubated after 7 days of initiation of mechanical ventilation. Our specific treatment regimen. The patient was given intravenous immunoglobulin at a standard dose of 0.4 gram per kg per day. He was given total 5 doses, requiring 5 days. His treatment started early in the ICU within almost 24 hours of his admission and presentation of symptoms. There was no major infusion reaction with intravenous immunoglobulin infusion. No plasmapheresis has been performed. We have taken concomitant measures, physiotherapy, pain management, Nutritional support were continued throughout his ICU stay. This slide shows progressive improvement in his muscle strength. By the day 3 of intravenous immunoglobulin, upper limbs began showing anti-gravity movement, that is significant improvement. On MRC grading, it is graded as 2 out of 5. Over the next few days and weeks, the strength improved steadily, reaching near complete recovery by 1 month. As we can see in this tabulation, on admission, patient upper limb MRC grading was 2 out of 5 and lower limb MRC grading was 1 out of 5, which is where when the patient was bedbound, there was flaccid quadriplegia, which is ascending and symmetrical in nature. By day 3 of intravenous immunoglobulin infusion, upper limb muscle power was the same, 2 out of 5. Lower limb muscle power was also same, 1 out of 5. Patient was able to perform minimal anti-gravity movement in upper limb and flicker of movements in lower limb. At the end of intravenous immunoglobulin infusion, which was day 5, upper limb and lower limb muscle power has improved. Patient was off ventilation. He was able to sit with support. By the end of 1 week, upper limb and lower limb muscle power has improved further. Patient was able to transfer with assistant and can sit a brief period of time without any support. By the end of 1 month, patient was surprisingly able to walk independently and can do all his self-care and do all the activities of daily life independently. This slide shows neurological progress of this patient. We have already discussed earlier. This trajectory aligns with favorable response to early intravenous immunoglobulin therapy. In this case, rehabilitation played a major role. Once my patient was hemodynamically stable, early I'm very sorry for the inconvenience. Rehabilitation played a very major role here. Once my patient was hemodynamically stable, early passive physiotherapy was started, which was progressed to active exercises and occupational therapy. By the end of 6 weeks, he started walking short distances with assistant and he was performing basic activities of daily life such as feeding, grooming, bathing, toileting and transferring with minimal help. By the end of 2nd month, he regained independence in most of the premorbid activities. His total hospital stay was 21 days with continued outpatient and rehabilitation follow-up. His outcome was excellent. Rapid ventilator weaning was done within 7 days. Near complete recovery has been achieved by 2 months. Many severe Guillain-Barré syndrome cases require prolonged ventilation, but early intervention can contribute to faster recovery, as we can see here. Here is a take-home message for our first case. Prompt respiratory monitoring and timely intubation can prevent catastrophic decompensation of any kind. Intravenous immunoglobulin infusion is highly effective when given in earlier phase. Aggressive rehabilitation is crucial for functional recovery and any prevention of any other functional deficit. Now, we will go to our second case, which is a clinical overview of this patient has been shown. Our second case is a 45-year-old adult male who develops sudden onset of asymmetrical flaccid paralysis of upper and lower limb. Soon after consuming an unusually large carbohydrate-rich meal at a family function few hours earlier. There is no past medical history except hypertension, which was controlled. There was no abnormality in thyroid function. My patient has no other history of similar paralytic attacks previously. On examination, he had more proximal weakness than distal, with reduced deep-tendon reflexes. His all sensations were intact, which differentiates it from my earlier case. Rapid respiratory compromise developed, impending respiratory failure. The vital parameters were given in the slide. His blood pressure was 140/80 millimeter of mercury. My patient developed tachycardia with a recorded heart rate of 112 beats per minute. He was subsequently showed signs of labored breathing with hypoxia. His respiratory rate has been noted to 28 breaths per minute. His saturation of oxygen has declined 86% in room air. We have attempted non-invasive ventilation initially. On neurological examination of this patient, MRC grading shows, in case of lower limb, the proximal weakness were more, which is 1 out of 5, that indicates flicker or stress contraction of movement. In lower limb, distal weakness was less than proximal, which is 2 out of 5, that indicates weakness of the movement when gravity is eliminated. In case of upper limb, there was as similar. Proximal weakness was more than distal. Proximally, it was 2 out of 5 on MRC grading, and distally, it was 3 out of 5 on distal movements, distal muscles. There was no neurological deficit. Focal neurological deficit was not present. Over a few hours, weak respiratory effort has been shown, and the patient respiratory efforts worsened rapidly with shallow breathing. Arterial blood gas analysis reveals time to respiratory failure with respiratory acidosis due to carbon dioxide retention. As we can see, pH was 7.1, which is suggestive of acidosis. Partial pressure of carbon dioxide 64 millimeter of mercury. Partial pressure of oxygen 59 millimeter of mercury. Bicarbonate level 35 milliequivalent per liter. My patient required intubation and was placed on mechanical ventilation for 48 hours. Here we have selected the mode SIMV, which stands for Synchronized Intermittent Mandatory Ventilation, as I have described earlier. We can see in the investigation findings of this patient, his potassium levels were critically low initially, which is 2.02 millimole per liter. After 24 hours, potassium levels further dropped to 1.82 millimole per liter. His magnesium level was normal, as well as his thyroid panel tests. The ECG showed classic U wave, which is persistent with severe hypokalemia. All these findings excluded Co-chairperson syndrome and pointed towards our recent case, that is hypokalemic periodic paralysis. This slide shows electrocardiography of severe hypokalemia, that is consistent with the patient with Co-chairperson syndrome. Here, there is bradycardia with prolonged PI interval, prolonged QT interval, ST segment depression, and T wave inversion. U waves has been best seen in the precordial leads, primarily in the lead V2 to V4. There is slurring of T waves into U waves. The red arrow indicates prominent U wave, the black arrowhead indicates T wave inversion, and the blue arrowhead indicates ST segment depression, as we can see in the slide. Despite potassium replacement, hypokalemia persisted initially. Gradual improvement of serum potassium level was seen from day 2 onward. As we can see, day 2, potassium improved to 2.6 millimole per liter. Day 3, potassium level improved to 3.1 millimole per liter. By day 4, potassium was corrected. It was 3.7 millimole per liter. His muscle power was gradually improving from MRC grading 1 out of 5 to MRC grading 3 out of 5. His respiratory muscle strength were also improving. After meeting all weaning criteria, the patient was successfully extubated after 48 hours of initiation of mechanical ventilation. As we have seen in the earlier investigation findings, his thyrotoxicosis has been ruled out. We have initially considered Guillain-Barré syndrome but excluded as patient's sensation was normal and he rapidly responded to potassium replacement therapy. All other metabolic and renal causes has been ruled out. So my final diagnosis was hypokalemic periodic paralysis, which has been triggered by a history of carbohydrate-rich meal. Management approach of this patient was focused mainly on controlled potassium replacement therapy using syringe pump at an infusion rate of 10 milliequivalent per hour. We tried to avoid rapid correction of this patient. Mechanical ventilation has been continued with close monitoring. We have established central venous access. Continuous electrocardiography and frequent electrolyte monitoring were essential in this case. Dietary advice included avoidance of carbohydrate-rich meal during recovery phase. My patient achieved full recovery of muscle strength by day 4 here. The key learning point of the second case presentation is severe hypokalemia can even cause respiratory failure requiring mechanical ventilation. Carbohydrate-rich meals are significant triggers in case of hypokalemic periodic paralysis. Slow, controlled intravenous potassium correction via syringe pump infusion at a rate of 10 milliequivalent per liter is essential. Awareness of dietary trigger is critical for long-term prevention. Both these conditions can cause respiratory failure, but their management is entirely different. The following 2 slides summarize the key distinguishing features between Guillain-Barré syndrome and hypokalemic periodic paralysis. Thank you, sir.